Greetings, ladies and gentlemen. I would like to present three cases that illustrate the importance of making a diagnosis. The first case is an unusual cause of heel pain. This gentleman came into my office. He was 26 years old and he had had a sore heel for 18 months. The pain was global, not on the plantar side. It occurred day and night. He had no history of penetrating injury, drug abuse, or any form of systemic malaise. Examination: the patient was blind. His gait was normal. He was able to take weight on the foot. He had a slight swelling on the lateral border of the heel and calf and a little bit of tenderness laterally. He had a normal range of motion in the ankle and subtalar joints. Plain x-rays taken certainly showed a little bit of lucency in the lateral calcaneus, which you could see on the lateral and the axial views. CT scan, once again a lucent area in the calcaneus. MRI scan, quite a deal of bone marrow edema, expansion of the lateral wall. Highly abnormal. Question: how did the man become blind? Answer: he had had retinoblastoma in childhood with enucleation of one eye at age 2 and the second eye at age 4. I got in contact with the Children's Hospital where he had had his surgery, and he was originally treated and had chromosome analysis, which advised us that his chromosome anomaly was the 13RB1 locus anomaly, which I'm sure you're all familiar with, and that this anomaly particularly predisposed him to osteosarcoma later in life. He underwent a biopsy, and in fact the poor chap had a metastatic retinoblastoma and he's currently undergoing chemotherapy. Second case: a 54-year-old gentleman got his foot caught at work. No snap or pop in the ankle or Achilles region. Examination: he walked with a marked limp and had a palpable defect with a positive Thompson test. He came in with an ultrasound suggesting an Achilles tendon rupture, and no plain x-rays were taken. The people that saw him placed him in a boot, but naturally he found the boot uncomfortable, so he took it off in bed and took it off in the shower. I saw him in consultation and I didn't like the look of it, so I took a plain x-ray, and the plain x-ray shows calcification some 4 centimeters above the Achilles insertion. So in fact what he had done was avulsed the Achilles insertion, and the Achilles was sitting halfway up his leg. This patient would never have healed in a boot, and the surgical repair was certainly mandatory. Third case: a 35-year-old gentleman who was doing Thai boxing in February noticed pain and swelling beneath the second MTP joint, lasting approximately 6 months. On examination, he walked easily on heels but less easily on toes, and there was a slight splaying of the second and third toes. He was tender at the insertion of the plantar plate, at the base of the proximal phalanx, and the joint felt mildly unstable. I took a plain x-ray and noticed once again splaying of the second and third toes, see the gap between, and he had an MRI scan performed which showed bone marrow edema at the base of the phalanx and an obvious tear of the second plantar plate. So the diagnosis here was a second plantar plate tear, unusual in 30-year-olds but does occur occasionally. Treatment initially: taping, insole, avoidance of impact, surgery if not responding. Take-home messages: there is absolutely no substitute for a good history and physical examination. All three of these cases had abnormal plain x-rays, and only one of the patient had had an x-ray. The adage in medicine that you see what you look for and recognize what you know is absolutely critical. And always try to make a diagnosis before you suggest treatment.